your sites in the body. Well, not really the body, but the heart. So located in the right atrium. So if you look up at my little cat heart thingy, think about it like the person is facing you. The person is facing you. Receives blood from the right coronary artery. It is the fastest pacemaker, so it has the fastest intrinsic heart rate of 60 to 100. Impulses spread through the intramodal pathways, causing depolarization. It's like a wave. Think about it like a wave. When one starts, it just kind of passes this way along. It's like dominoes. So once it starts in one place, it just spreads along. Electrical impulses move through the SA node into the AV node. Okay, so once we start this process, it's like dominoes. It goes from the SA node down to the AV node. SA node down to the AV node. So then after the AV node, where does it spread? Down to the Purkinje fibers, okay? So it's just going to, again, it's like dominoes. It starts at one place, it innervates, and then it continuously moves down. So impulse conduction is delayed so that the atrium will empty into the ventricles. So essentially, we get delayed right here. And sometimes we get delayed too much, and that's where you get into your bundle branch blocks. Your bundle branch blocks, and it's actually like right in here. It's right below your AV junction, like right there. Okay, so once you get that really, really big delay, we say that you have a block, a bundle branch block. And that gets into a whole other level of things that we're going to talk about in the very near future. So conduction pathways that allow currents to bypass the AV node. So again, sometimes we don't hit the AV node. Sometimes we skip it. We have the Mayheim fibers that extend down into the ventricles, the James fibers in the intranodal pathways, and the bundles of Penn, which enables early depolarization of the ventricular tissue. So again, guys, when we talk about these pathways in the heart, your heart has a couple primary pathways that are constantly used to spread these electric pulses along and to cause depolarization and repolarization. Now, occasionally we have a situation where someone has an extra pathway that shouldn't be there. Can anyone give me an example of something that we see, I wouldn't say regularly, but it's a well-known extra pathway? Wolff-Parkinson-White, absolutely. Wolff-Parkinson-White is when you have an additional pathway in the heart that is used so often that it becomes a rhythm, becomes its own identifiable rhythm. In this situation, primary way that this person is going to get fixed and get rid of this Wolff-Parkinson-White, they have to go in and get ablated. They actually have to have that additional pathway removed surgically. They go in and they ablate it. So, SA, are you good?
Are those three alternative pathways that they put up there, are they existent in everyone and they're occasionally hyperutilized, or
yes, they're there, but they're not always going to be used.
So like Wolff-Parkinson-White is just an odd added on. Okay.
Yeah. All right. So it's just like, I mean, think about it this way. It's like, you know, you take a detour off of 995 and it's a dirt road. I mean, it's there, but you shouldn't be driving on it. Depolarization. All right. So listen, depolarization occurs when muscle fibers are stimulated to contract. This occurs through a change in contraction of the electrolytes across cell membrane. And this gets into our sodium-potassium ion exchange pump. Okay, so this is where we talk about our chemical mediators that control our heart function. Remember when Sturge came in and was talking about the sodium-potassium ion exchange pump? What do you guys remember from that?
Probably something about me getting made fun of or something.
Something about what?
It's active and it uses energy.
Okay, so it's an active thing, sure. Well,
sodium pours in, potassium out, charge of the cell, and the cell becomes more positive, it polarizes.
okay, good. So we're talking about an exchange. Yeah, we're talking about an exchange of electricity or electrolytes that's actually going to change the charge of the cell itself. So all of your myocardial cells are bathed in an electrolyte solution. And that's important to understand. Just like everywhere in your body, we have electrolyte solutions everywhere in our body. Okay, our cardiac cells are bathed in this electrolyte solution. Chemical pumps maintain the concentration of what we need to have for potential contraction in our heart and potential depolarization. So when we have a stimulation or a stimulus to conduct and conduct electricity, the permeability of the cell wall actually has to change. It's like becoming Swiss cheese. And this permeability has to change to allow certain things in and certain things out. So sodium ions are going to come in. The calcium ions are also going to come in. The sodium ions are going to be what causes that change to depolarize, but the calcium is actually going to be what maintains that contraction. Okay, so the sodium is going to cause that contraction, but the calcium is going to maintain that contraction. And those are two different functions of two different electrolytes that you guys have to understand. Now, when this happens, it actually becomes a mechanical contraction. So we move out of the realm of electricity and we become a physical contraction, become mechanical. So again, back to that primary concept that when we're talking about cardiac muscle, we're talking about the electrical contraction, we're talking about the mechanical contraction. And this has to be like foundation, because when we get into physically taking over the function of the heart with pacing and overdrive pacing and sorry guys, my steroids are like not working tonight, I'm dying. If I actually pass out, fix me please. So that's all I ask, just fix me. Don't you even dare. I have an albuterol inhaler in my bag.
You just said everybody's new students weren't learning.
Listen, that's great. Not learning. All right.
Bring them over and
So long and short of
assist.
long and short of it, okay.
Trumpet.
You know, we move into that realm of mechanical contraction, and this again, we're going to get back into overdrive pacing. We're going to get into pacing for our bradycardic rhythms, and we're going to get into synchronized cardioversion and unsynchronized cardioversion. So understanding that there are two different parts of the heart that are working together to make it function is really important. So repolarization begins with the closing of the sodium-calcium channels. Sodium ions pump out and potassium ions start coming in. So active transport is when ions are moved against the natural gradient. That's active. Okay? They're moving against the active, the natural gradient. So a myocardial cell must be fully polarized to respond normally to electrical stimulus. If it's not fully charged, you're not going to get the bang for your buck that you're hoping for. Okay? So we have this strange thing we're going to learn about in the future called R-on-T phenomenon. And this is the very beginning of learning what that R-on-T phenomenon is, because it's going to be a big part of future classes. So I want you guys to understand this concept. The myocardial cell must be fully polarized to respond normally to electrical stimulus. Okay? You can't have a half-charged cell. Refractory period is when the cell is depolarized or in the process of repolarizing. Okay? The absolute refractory period is when it's completely depolarized. It has no more charge left in it. It's completely out. It's empty. It's done. And then you have relative refractory period, where it's partially repolarized. It has some potential to help. Again, if we hit a cell, if we hit a myocardial cell that's in that relative refractory period, and it's partially utilized, it's not going to get effective. Or it's not going to get affected. It's going to keep fixing itself. It's going to keep healing. It's going to keep repolarizing. So again, you're not getting that bang for your buck that you need. Is everyone okay with that concept? Everyone is okay with that absolute refractory period versus that relative refractory period? That's an important concept, so I need like a yes or a no. Yes? I got sort of, I don't even know what that is. Dude, okay, that was like The Exorcist. All right. So moving down from the SA node, which is your primary pacemaker site, into our secondary pacemaker sites. Okay, we talked about these things. Any conduction system component can act as a secondary pacemaker if the SA node is damaged. The further removed from the SA node, the slower the intrinsic rate of firing is. Okay, we talked about that. Lower is slower. Lower is wider. So when you see a slow rhythm, that's below what? 60. Good. Below 60, because remember, SA node is 60 to 100, so we have to be below 60 to really consider that we're probably outside of that SA node area, okay? Once we get down lower, we're going to start seeing that rate drop, and we're going to start seeing our complexes widen. That's how we know we're lower. And we're going to start losing parts of this. So, just out of curiosity, if I'm now down out of the SA node, and I'm starting to lose this, I'm starting to lose my atria, okay, and I take away that. I got to get my markers, my color markers. What do I now know when I see that?
But your atrium isn't contracting at all?
My atria is not contracting. There's something not happening in my atria. Okay? So now what happens if I have something like this?
Fire in your voice.
Late?
So what do we say about that? Something atrial, right? I don't have enough information out of 2 P waves, but I know that I've got 2 P waves, so it could be atrial flutter, it could be atrial, multiple things. Okay? Could be a PAC, premature atrial contraction. It could be anything. But I know that when I have a change in my P's, or I add a P, or I take away a P, I know that there's something going on with my atria that shouldn't be happening. So then what happens when I have this situation occur? If that's normal, and then all of a sudden I go like this.
It's taking a long time to depolarize.
What's that?
Ventricular?
So what's happening down in my ventricles? I get what?
High resistance.
There's something definitely happening in my ventricles because it's wider. When I get ventricular widening, my complexes widen. I know I'm taking too much time down in my ventricles. There's something happening there. Okay? So again, I have these 3 sites, the SA node, the AV junction, Purkinje, but I know that when anything happens that's going to change my complexes, I know that there's going to be, bless you, I know that there's going to be something I have to keep thinking about. So again, damage occurs naturally as we get older. So what does that statement say about kids? Are you typically going to have a kid with a heart issue? Develop a heart issue? No. If I have a kid with a heart issue, what happened? They were born that way. It was a birth defect, usually. Okay, something happened. So when you see a kid, you put them on the monitor, and you see all these strange complexes, and you see widening QRS complexes, or a drop P, or a whatever, what should we do? Run. Yeah, but well, I mean, we can talk to mom when we're running, but I run. Yeah, run. Okay, because this is definitely not normal. All right, so measuring the heart's electrical conductivity, or conduction active. Conduction activity shows a series of waves and complexes on the EKG. So we were just talking about that. So this is all stuff we're familiar with, right? All things in the bag, right? So what is our P? Depolarization of the atria, right? We got our PR, which is what? You guys aren't even trying. Okay, so it's depolarization of the atria, and it's the delay right here at the AV junction. Okay, then we got our QRS. What is our QRS going? Yep, it's our ventricles depolarizing. Okay, and I got our ST segment. So it's between the ventricular depolarization and the start of repolarization. Now here's where we get funky. Okay, if we have an acute myocardial infarction that's ST segment elevated, this is where we're going to start looking to find our damage. Okay, right here, this goofy little thing right here. Now our ST segment actually starts with something called a J point. Okay, the J point is not visible right now. The J point is actually going to end up being like right there at the very bottom of the QRS. When our J point becomes visible and it's dipping below the isoelectric line, the isoelectric line is that line that everything travels on. You can draw a line right through your complexes that way. It's a horizontal line. That's the isoelectric line. When that ST segment lifts a certain amount above the isoelectric line, we know that there's some kind of damage occurring. Now, not all heart attacks are ST segment elevated. But if you see ST segment elevation, there is a very good chance that it's a myocardial event. Okay? So that's where we're going to start looking for all of our damage. And that's where we get into 12-lead EKGs and why 12-lead EKGs are so very important. What's our T? It's when our ventricles become repolarized. Okay, and our R to R interval, it's the time between 2 ventricular depolarizations. So if I'm going to feel a pulse, where am I going to feel it? If I'm looking at the monitor and I'm feeling for a pulse, what should I say every time I feel a beat? A QRS complex, absolutely, because that QRS complex is hopefully, here's to hoping, what's generating my pulse rate. Okay, so every time I see an R, I should feel a pulse rate. So my R to R should give me my heart rate. And my R to R should give me my pulse rate. But remember what I said in the very beginning. Now we're thinking beyond pulse. We're thinking heart rate. And heart rate doesn't have to be the same as pulse rate. Adding that whole other thing. So this table is in your text, and I think it's a really good reference. When I was going through school, I had a similar thing, and I actually printed it out and I laminated it and I put it in the back of my little card holder, and it was just something that really helped me learn it. I would highly suggest taking that, writing it down, and really studying this, because if you know what is causing each complex wave and form, then you're going to know what it correlates to, and you're going to be able to read anything. I'm going to give you guys a word of caution. When I was going through medical school, someone told me, if you can recognize it on the monitor, you'll be just fine. If you can recognize it, you know how it looks, you'll be all right. Just get a basic understanding of how it looks, and you'll be able to identify anything. That's a bunch of crap. Don't get in the habit of learning to recognize it by naming it what it looks like. Be able to break it down specifically. Know what the P wave represents. Know what the QRS wave represents, or complex represents. Know what the ST segment is. If you know that, you can identify anything. And I truly do believe that. No, the monitor is, it lies. It lies. That's the only thing I can say about it. Does anyone actually here, does anyone work with a medic who has it turned on? Has the automatic, yeah, you do?
They're all monitors.
All our monitors.
Okay. See, the places I have worked in the past, we actually have turned it off, the auto interpret, at the top of the 12 lead, because so often it's wrong. Like, I mean, and it's blatantly wrong. You got someone in sinus, normal sinus rhythm, and it's like VTAC with left bundle aberrancy, and you're like, what are you talking about? So again, don't trust your monitors, trust yourself. Don't rely on that, because I've seen medics get burned. All right. Is everyone okay with the different parts of the heart and which waves they create, and which complexes they represent? Because that's really the basis for cardiology. Everyone good? I need a thumbs up from everyone, or a thumbs down. Just thumb up or thumb down. Thumbs like, that's okay too. All right, G, you good? Thumbs up, thumbs down. Thumb sideways. Sideways shaking. More towards up or more towards down? More towards up. That's positive. Okay. Okay, good. Chris? Good. Brian? AJ? Good. Amanda? Okay, more towards up or more towards down?
More towards up.
Okay, that's positive. I'm going to take it. Chris? Okay. Mike? AJ? Damn it! I'm going to get your name right. Sorry, kids. Mayor, I'm so
I'll
sorry.
say a compliment first of all.
There you go, there you go.
Hey, I don't think it's a
Yeah,
compliment.
I gotta go over it, but yeah.
Yeah, okay. Good.
One of those faces.
Colin?
Right.
What's up?
Good, bad, indifferent?
Thumbs up, thumbs
Oh
down.
my God!
Put your thumb up.
Thumb up or thumb down? Thumb sideways?
Thumb up.
Is this like a secret handshake?
Are you good with this? Are you not good with this? Or are you starting to become good with this?
Oh, I'm solid. I'm rock solid.
Okay, rock solid. Thumbs up? Thumbs up? Okay, good. All right, look, I gotta make sure, because guys, this is the basis. This is the basis. We're moving into the big leagues here. I need to know that you guys are good. All right? Okay, so let's talk about this. We're switching gears a little bit. We're gonna stop talking about waveforms and complexes, and we're gonna move into our nervous system control of the heart. Okay. I really am not dying, I swear.
What?
I'm really not. All right. So autonomic nervous system controls involuntary actions. This is nice because I don't want to have to get up in the morning and think about breathing. I don't want to have to get up and think about not pissing myself. And I don't want to have to get up and think about swallowing my spit so I don't choke. That's all positive. I don't want to have to think about that stuff. So it works with the voluntary nervous system to allow bodily functions to proceed smoothly. Okay, so then this breaks it down. This is a great chart to have. Your nervous system is in two parts. You've got your voluntary and involuntary. Okay, and your involuntary is your autonomic nervous system, and it subdivides into your sympathetic and parasympathetic nervous system. And when we're talking about sympathetic, we're talking about alpha and beta properties. Alpha and beta properties. And beta can further be subdivided into beta 1 and beta 2. Okay? So we're talking about autonomic nervous system conductors. We're talking about sympathetic nervous system. Okay? And our sympathetic nervous system is going to speed up the heart. Why? Why do we want our give me an example of why my heart rate should be elevated, Brian. Why do I want my heart rate to be elevated?
So you can react.
Sure, absolutely. Someone jumps out and yells boo. I want to be able to react. My patient grabs my stethoscope and brings me forward by it hanging around my neck because I'm an idiot and I wear my stethoscope around my neck and punches me in the face.
You punch him back.
Yeah. Hello. Okay.
Finally get to see me lose
Just saying.
too.
Listen, I always swore that if I got hit or punched or in a vehicle accident while I was working, I was going to just wet myself and fall down in a seizure and then like claim disability for the rest of my life.
You've never gotten
And
hit
I
by
got-
a patient?
I was going to say, no, I said this is when I started,
Oh.
okay? And then after like the 6th or 7th time, it's like, whatever, it's all right.
You peed
I got
yourself 6 or 7
stabbed
times.
at work. I legitimately got stabbed and I was wearing a vest, thank God. And it was funny too because I had this like full-on fight with my then boss, Tim Mengel, because he wanted us to get the side protection on the vest, and they're so uncomfortable. Oh my God, especially if you're a girl. And they've got all this like bulk here, and let me tell you something, seriously, it stopped it. I was so excited.
Which
because I
one
didn't want
stabbed
to
you?
die. It was a knife, it was like about this big. It was
The knife was that big?
it was a shiv. It was from the Upper Darby Police Department. They had the guy in holding, and he had like a little shiv.
A shank?
And the guy, yeah, to shank. Yeah. But anyway, and he came up and he got me, he was trying to get me in the ring. And it stopped it, so. But yeah, anyway, so enough about that. So sympathetic nervous system speeds up the heart. We want our sympathetic nervous system to react in case we need increased cardiac output or more oxygen to keep us safe. Parasympathetic nervous system regulates the vegetative functions. So again, sympathetic versus parasympathetic. At this point, we really should know this, right? This has been just drilled into you. Drilled into you. So let's talk a little bit about sympathetic versus parasympathetic when we're talking about cardiac function. Our parasympathetic nerve acts on the SA node through the vagus nerve. Remember we talking about the vagus nerve? How did Elvis die? Pooping. Where was he pooping?
He's still alive.
In Vegas.
It wasn't actually in Vegas. It was like North Carolina or somewhere like that. But when I think Elvis, I think Las Vegas. So he died pooping because he was stimulating his vagus nerve. Okay, so just think about Elvis dying on the toilet. So again, our parasympathetic nervous system innervates works on our SA node through our vagus nerve. When we're talking about our sympathetic nerves, we're talking about releasing epinephrine and norepinephrine. Sorry, can you guys go back? Good? Good? Okay. Parasympathetic nervous system sends message through the vagus nerve, which can be stimulated by pressure on the carotid sinus. So we used to tell people to do carotid massage. If someone was really tapping away, we used to tell people to do carotid massage, bilateral carotid massage. And we stopped telling them, or we told them to stop doing it because people were passing out, and we were also breaking loose plaque. And we were sending people into cardiac arrest. So that's why we don't do that anymore. But give me some examples of how we might be able to stimulate someone's vagus nerve. Just by reading that up there. Straining against a closed glottis, which we call the Valsalva maneuver. How would bear down? What does that mean? I don't understand bear down. What is bear down?
Act like you're gonna poop
You're
without
gonna
nothing
poop,
coming out.
but don't
You
poop.
don't poop.
Okay, absolutely. Act like you're going to poop, but don't poop. Okay, so bearing down, straining against a closed glottis is actually what we call the Valsalva maneuver. I remember the other day I was talking about that time I went to the dialysis center and someone had vaginal stimulation. That's what this guy was trying for. Okay, they didn't get it, but this is what they were trying to tell me that they did, where they have a Valsalva maneuver. They vagal down. Okay, they're trying to get the patient to vagal down. So there's a lot of things that we can do pre-hospitally that are really non-invasive to drop someone's heart rate. Okay, so this is where we start actually having some control over what the heart is doing. So if you have someone who is in a tachycardic rhythm, I mean that heart rate is going way too fast to be a good thing, one of the first things we can do is say, sir, can you close your mouth and try to bear down? Like you're going to go to the bathroom, please don't. Let me put a chuck down. Okay, but please bear down. That's one of those ways that we can actually start that process of hopefully slowing them down. We can have someone, I had a partner once who had a straw, just like, I think it was at a bar or something. He told me about it. I don't know if I believe it. But anyway, he said that he had them blow through a straw. I had someone ask someone to blow out the candles, but keep blowing to really bear down a little bit. But anything you want. There's sometimes where you can take ice and put it on the back of your neck, ice on the eyelids, will stimulate your vagus nerve.
More celebrity kids.
Children, yeah. So if you have a kid who's really tapping away, you need to do something about it. Ice often works. So again, this is really us having external control over an internal process. I'm sorry, that's pretty phenomenal when you guys think about it. that we externally can have so much effect on what your body is doing. That's pretty amazing. Okay? It's like, you know, there's people who have no pressure points and stuff. They can make people pass out with like certain grips and whatnot. I mean, it's just cool. I'm just saying. So again, we can actually cause stimulation that can lower someone's heart rate. If the brain senses that the heart should slow down, it's going to send electrical impulses that's going to travel to the SA node. And it's going to cause the release of acetylcholine, or ACH. Okay? The acetylcholine is then going to signal the node that, whoa, you need to slow down. Slow your roll. You've got to slow down, SA node. Knock it off. Okay? Not only are we going to send that hold on. I'm good, I'm back, thank you. Thank you, Mr. Chairman. So not only are we going to send that acetylcholine to the SA node, we're also going to send it as a reminder, a gentle reminder down to the AV node, just in case our SA node is not going to listen. Okay? So that's two places that we're going to send our acetylcholine to say, hey, chill out. So when you think acetylcholine, think about parasympathetic nervous system. Think about slowing down the heart. Okay? And this is a nice little thing. Doo-doo-doo, up here, hey brain, slow down! It sends chemical mediator, doo-doo-doo, down to the SA node. Okay, and this chemical mediator is called what? Acetylcholine. 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 Okay. It's called what? Acetylcholine. Stop. Don't be that guy. All right, so sympathetic nervous system. Again, we're talking about adapting to changing demands. So now we're outside of parasympathetic nervous system. Now we're actually talking about, wanting to increase the heart rate. We're not talking about lowering the heart rate. We're thinking about now increasing the heart rate. So as we're talking about increasing the heart rate, we're also talking about strengthening the cardiac muscle through the force of contraction. Okay, so chronos is increasing the rate. When we talk about increasing the strength, we're talking about inotropic. Okay? Chronotropic and inotropic. Two different words you need to know. Chronos is time, so chronotropic is rate. Inotropic is force. Good? Because you need to know that stuff. All right, other adaptive responses to increase cardiac output are then going to take place. So again, when we're stimulating our body, we're saying we need more oxygen, we need to increase our heart rate because we need to increase our cardiac output, all that good stuff. We're going to start stimulating our sympathetic nervous system. So in response to more need for more oxygen, the brain sent a message through the nerves to the heart. It's going to conveyed through the release of norepinephrine. So now our chemical mediator is not acetylcholine, it's norepinephrine. Okay, what's another term for norepinephrine? Go ahead.
Noradrenaline, or, yeah.
Noradrenaline. Okay, good. All right, heart speeds up to prevent lactic acid buildup. Now, here's the thing. Lactic acid. We don't want lactic acid. What does lactic acid cause?
Cramps.
Cramps. Okay, we don't want heart cramps. That's no good. All right, no heart cramps. Don't want them. Okay, epinephrine is used if intense stimulation occurs. So, classified drugs that act on symptoms. Now, I didn't want to go this far. Dang it. Hold on. There was something else I want to talk about with this one. When you're talking about using epinephrine pre-hospitally, we know that epinephrine is going to increase sympathetic nervous system tone. Okay, so pre-hospitally, if I have someone who is really bradycardic and I can't use atropine on them, our next drug of choice is going to be epinephrine. All right, because I want to increase their heart rate. If I have a kid, I can't use atropine. I'm going to use epinephrine on them to increase their heart rate. And this is why I have to stimulate their sympathetic nervous system. When I'm talking about stimulating my sympathetic nervous system in response to a bee sting. Okay, what does a bee sting cause? What does my heart do when I get stung by a bee and I'm in anaphylaxis?
Increase.
End stage. Think end stage. It's going to decrease. Okay, end stage anaphylaxis, you're going to start decreasing. If I give epinephrine, I'm going to increase my heart rate, and I'm going to actually be stimulating externally my sympathetic nervous system. So if I'm stimulating my sympathetic nervous system by entering, and giving you guys epinephrine, I'm going to increase my heart rate. I'm going to close my blood vessels, right? I'm going to start contracting them, and I'm going to start seeing that person kind of go from a dilated mess to coming back to normal. And that's what I want to do. So I just want to kind of start you guys thinking about this stuff, that we are now in a situation where we are giving medication. We're seeing our actions have an immediate effect on these patients, and this is one of them. We use epinephrine all the time. All right, so drugs that act on the sympathetic nervous system. We classify these medications by the receptors with which they interact, alpha or beta, okay? So we have our heart, our arteries, and our lungs when we're talking about cardiac system, that we're talking about these receptor sites. So we're talking about our heart. We're talking about increased heart rate, our positive chronotropic effect, and that's beta 1. Think about one heart, beta 1, one heart. Think about beta 2, 2 lungs. Okay, so beta 2, 2 lungs. Beta 1, one heart. Make sense? Increased conduction velocity, positive dromotropic effect, beta 1. Arteries constriction is going to be an alpha property when we're talking about our arteries. So think A, alpha artery, right? And then we're thinking our lungs, back to beta 2, 2 lungs. So this actually makes a lot of sense, right? Alpha, arteries, beta 2, 2 lungs, beta 1, one heart. This should be easy for us to remember, right? Sadly, it's not. You get pre-hospital people, paramedics, advanced EMTs, pre-hospital nurses, administering medication with properties, and they give them without regard to what other damage it's going to do. All right? So, I know, I love these little guys. Look at these little, aren't they cute? Yeah, I'm an alpha drug. Yeah, I'm a beta drug. All right.
You don't have a kid at home, right?
I know, right? Listen, that kid, I would do anything for that kid to make him laugh. So, sympathomimetic drugs imitate the actions that occur naturally. Okay? So you have your sympathetic chemicals. So, I love this. This cracks me up, okay? Increased heart rate, increases force, increases automaticity. Yay! So what's increasing all this stuff?
Cardiac output.
Okay, so cardiac, thank you. Cardiac output is going to increase, right? But what's going into the heart? What's this little dude supposed to be? What is he?
A beta 1.
He's a beta 1, right? So if I want to increase my heart rate, I'm going to give him beta 1. I'm going to give him a sympathomimetic that has beta 1 properties, right? Now, I've got bronchodilation, okay? Beta 2, right? Beta 2. And that's going to cause what?
Bronchodilation.
Bronchodilation, thank you. Okay, and then vasodilation. Okay? Vasodilation. So, I'm sorry. Isoproternol is pure beta agent. Pure beta. No alpha properties at all. Okay? All right, so this cracks me up, okay? So no alpha receptor. So this is a little alpha guy, and he's not wanted in the heart. Okay, so he's not going to have any effect here. Not much happening down in the lungs. But when he gets down to when he gets down to the arteries, he's going to cause shrinkage. He's going to tell them to kind of shrink here. And what happens when your arteries shrink? What happens when your vessels shrink?
Increased blood pressure.
You're going to increase blood flow. Why?
You're in a constricted space.
We're in a constricted space. What's that going to increase? Pressure. The whole idea for this is that we want to increase our pressure. So beta sympathetic agents classified as beta 1, which is an adrenergic antagonist or agonist working on cardiac beta receptors. And then beta 2, which is adrenergic agonist working on pulmonary beta receptors. So again, back to that beta 2, 2 lungs, beta 1, 1 heart, so on and so forth. Sympatholytic blockers work by beating agents to the receptor sites. Are you guys good? Oh, I know. I got you first. What's that, Jose? So, wow, kids. All right. So beta blockers. So talk to me a little bit about beta blockers. We know that beta stimulation does what?
It increases cardiac contractility, conduction.
Mm-hmm. So if I have a beta blocker and my beta stuff can't get in, now what happens?
Slow it down.
slow down the heart rate, but also it's going to block it from acting. So here's the problem with this. This is where we get scared pre-hospitally. If I have someone who normal function would raise their heart rate to respond to a situation I'm having, to meet my myocardial oxygen demand, meet my cardiac output needs, meet all these things that I normally would just increase my heart rate for, and they're taking a beta blocker, they can't increase their heart rate. So you have traumas. People who are beta blockers can't increase their heart rate to compensate for that blood loss. Okay, you have people who are in a significant amount of pain with low heart rates and low blood pressures because they're on beta blockers. And then you have us coming in and we're like, well, it can't hurt that bad. Your pulse is like normal. It can't hurt that bad. Your blood pressure is normal. And then you look at their medication list and you see beta blockers. What's a quick and easy way to identify a beta blocker? OL, yeah. A beta-lol, metenolol, a beta-lol, toprol, yeah, all those LOLs at the very end of everything, it's going to be a beta blocker. So if people are on beta blockers, they can't increase their heart rate. So we have to have a high index of suspicion. If we have someone with significant trauma and they're elderly or they're middle-aged and overweight, we need to start looking at their med list and thinking maybe they're on something that's stopping that heart rate from increasing naturally.
Do we have any medications that are the antagonists to that we could stop that beta blocker from happening?
I'm glad you asked. We're getting into that, yeah. Because we can absolutely pre-hospitally treat beta blocker overdoses. Yeah, we can. So excited. All right. So beta adrenergic blockers occupy beta receptors, okay? So again, it's a situation where we're stopping that beta, we're stopping them again. I know, we're back. So again, you know, we're wheezing and we're stopping and we're not able to give them what we need. We're not able to actually start increasing that dilation that we need in the lungs because we've got this beta blocker in there. All right? And again, the same thing happens down here with with our vessels. We can't dilate. All right? We're just stuck. So major autonomic agents, atropine, okay, parasympathetic blocker used to speed up the heart. We talked about atropine a little bit. So if I have someone who is bradycardic and they're symptomatic but they're stable, then I might think about giving them some atropine. If they're unstable, and you guys need to write this down, anyone who is unstable from a cardiac rhythm, you fix it with electricity. Anyone who is unstable from a cardiac rhythm, you're going to fix it with your monitor. You're not going to reach for your drug box. Okay? Because drugs take time and electricity is instantaneous. So we need to have a very firm grasp, pre-hospitally, of what stable looks like and what unstable looks like. Because at a moment's notice, we might be called upon to say, listen, we're going to use some electricity. Or, hey, listen, you're holding your own. Let's think about maybe turning you around with some medication. This is where knowing our side effects comes into being really important. So give me an example. Make up a patient, AJ, make up a patient who is right on the cusp of stable versus unstable and they're bradycardic. Give me a patient. What are their signs and symptoms where they're right on the edge? What am I going to expect to see?
Shortness of breath, have problems breathing, like you said.
No, they're unstable. It's not on the cusp. If you're having a hard time breathing, you're unstable, I'm lining you up.
They got stung by a bee in their airways.
Experience.
I'm talking about cardiac.
So, heart rate in the 50s.
Okay, so they're diaphoretic, heart rate in the 50s.
Blood pressure systolic about 100.
Okay, systolic is 100. Are they holding their own at this point? Starting, yeah, right. Because no, we don't say that they're really getting into that shock range until what? 90. Good. Okay, so they're still kind of holding their own. They're diaphoretic, chest pain maybe, but their blood pressure they're holding their own. Respiratory distress, none. Change in mental status, no, they're good. All right, let's start playing around with some atropine. Absolutely. Anyone know the dose of atropine? 0.5 milligrams, 0.5 to 1 milligrams. Good. Okay, what's the max dose of atropine? It's one of your drugs coming up. You guys haven't had it yet. Great. Beautiful.
Is this
Alright.
the same for IV and nebulized?
Why are we nebulizing atropine?
says in the book that we can.
Yeah, but why? Why would you pick that off of, over giving it IV?
I don't know, we haven't had the drug yet.
I'm trying to, well, I'm seriously concerned because I've never seen atropine nebulized. And I'm wondering what the example is.
I think, alright, so back in one of the earlier chapters, they said there were 4 medications you could give through ET tube, not that we would do that, but it was lidocaine, epinephrine, atropine, and narcan. So, I
I'm
think
just
that,
wondering why you
Is
said
it possible that you would do it for organophosphate poisoning?
Oh, okay, so maybe we're drying secretions through a nebulizer as well as giving it IV. Okay. All right. I've never actually had someone with organophosphate poisoning, but yeah, that makes sense. Oh, thanks for teaching me something. Cool. All right.
On that note, have a break.
Do you guys need a break? We can take a 10-minute break. We're moving. You guys want a 10-minute break? Go, go.
Log it up over here.
I don't want to hear about that.
Why would you treat them as totally asymptomatic?
I'm not psyched.
Why mess with perfection? No, they have to